Another topic for discussion is pulmonary hypertension. Here we see the relationship between vascular resistance and flow, and we can see that pulmonary artery pressure equals cardiac output times vascular resistance plus pulmonary venous pressure. Pulmonary hypertension is defined when the mean pulmonary artery pressure exceeds 25 millimeters of mercury. In order to get edema in the interstices and eventually within the alveoli, the wedge pressure exceeds 30 millimeters of mercury pressure. Pulmonary hypertension is defined when the pulmonary artery systolic pressure exceeds 30 millimeters of mercury, or the mean pulmonary artery pressure exceeds 25 millimeters of mercury pressure. There are many classifications of pulmonary hypertension. This one is based on the primary site of involvement. It can be precapillary or postcapillary. Precapillary include the parenchymal conditions of the lung, thromboembolic disease, the so-called primary idiopathic or essential pulmonary hypertension, congenital heart disease, a prolonged or large or both left to right shunt, pulmonary vasculitis, high altitude disease or Monge disease, pulmonary arteriovenous fistula, and peripheral pulmonary stenosis. The postcapillary group are related to cardiac decompensation, mitral valvular disease, left atrial myxoma or thrombus, and pulmonary veno-occlusive disease. The physiologic classification of pulmonary hypertension starts with increased pulmonary blood flow. This is the result of a left to right shunt, such as ASD, VSD, PDA. There can be a reactive vasoconstriction that leads to plexogenic pulmonary arteriopathy. A large or a prolonged left to right shunt or a combination of both would lead to this form of pulmonary hypertension. Hyperthyroidism and severe anemia and are other entities that physiopathologically lead to pulmonary hypertension. Increased pulmonary viscosity may be seen with polycythemia, with certain hemoglobinopathies, particularly sickle cell anemia, and with paraproteinemias. Restriction of the pulmonary vascular bed is another mechanism of pulmonary hypertension. This can be seen as a result of post-surgical resection of lung tissue, embolic syndromes, thrombi, tumor, fat, amniotic fluid, and foreign material, parasitic disease, particularly schistosomiasis, vasculitis, as noted with collagenosis and sarcoidosis, vasospasm, as seen in high altitude, drug abuse, the use of certain drugs such as amphetamines and cocaine, chronic obstructive pulmonary disease, and alveolar hyperventilation. Finally, obliteration of vessels, also observed with COPD, interstitial pulmonary fibrosis, pneumonopathies, and chest wall restrictive disease. Other causes of restriction of the pulmonary vascular bed include pulmonary veno-occlusive disease, compression or narrowing of the pulmonary arteries or veins, seen particularly in fibrosing mediastinitis and tumors, and the so-called idiopathic primary or essential pulmonary hypertension. Recently, a number of medications have been added to the long list that started with Aminorex, Crotalaria, etc., the so-called fen-phen combination, and several other drugs, particularly contraceptives, can lead to the so-called idiopathic pulmonary hypertension. Finally, conditions that cause elevation of left atrial pressure, particularly left ventricular decompensation, mitral stenosis, and masses in the left atrium complete the list of causes of pulmonary hypertension.